Welcome back, everyone. It's my pleasure and privilege to welcome Dr. Victor Herrera here from Orlando. Dr. Herrera, I'm so excited to talk to you about population health and clinical transformation. Why don't you begin by just introducing yourself, your title, your role, and your organization?
Thank you, Mark. My name is Victor Herrera. By background, I'm a physician trained in internal medicine and infectious diseases, and I now serve as Chief Medical Officer of AdventHealth Orlando in Central Florida.
Wonderful. Tell us a little bit, first of all, just a few basics about AdventHealth Orlando.
So AdventHealth is a large system in the United States. We have around 50 hospitals. We have 20 of those hospitals in the Central Florida region. And I serve as CMO of AdventHealth Orlando, which is the flagship hospital for the organization in the Orlando metropolitan area. We're a BC quaternary level medical center. And we cover a large population here in our area.
And you have the title of Vice President for Clinical Transformation at AdventHealth Orlando, correct?
That is correct.
Great, great. And when did you assume that title, or is it attached to the CMO title?
That was prior to the pandemic. I've been working in clinical transformation that, as you know, has been a priority for centers across the United States, connected to the goal of increasing value as defined by becoming more affordable and improving quality outcomes at the same time for our patients.
Wonderful. Well, Dr. Herrera, one thing I'd like to immediately reference is the article that you and Dr. Neil Finkler published in NEGM Catalyst from the New England Journal of Medicine on November 19th, in which you talked about how clinicians are moving beyond traditional roles and responsibilities, and in your words, have been called upon to drive change and innovation in their organizations. Tell us just a little bit, maybe summarize very, very briefly what you and Dr. Finkler said in the article, and then we can talk a little bit about the idea of clinical transformation together.
Thank you. So that article is really connected to what we see as a transformation of the role of clinical leaders that was accelerated by the COVID-19 pandemic. So if we go back to the beginning of 2020, as we were getting ready to start to see the first patients with COVID-19, and we had the opportunity to observe what was happening around us in the United States and in other places around the world. Here in Florida, I feel that we had a little bit of time compared to other parts of the country, like the Northeast, in terms of seeing our first COVID-19 surge. It became very clear to us as we were dealing with the possibility of our system being overwhelmed with patients that needed hospitalization, that we needed to think differently about how to respond to the potential demands that the COVID-19 surge was gonna put on in our system. So it was clear that just the traditional way to take care of things and to serve in our roles was not going to be enough.
Right. And the very title points out that there are a number of areas that need to be looked at. The title of the article is 5 Areas to Redefine the Clinical Leader of the Future. You looked at applying novel forecasting models, designing action-oriented data views, creating and leading external partnerships, transforming care while accounting for workforce instability, and uncovering and eliminating hidden disparities. Just real briefly, how did the idea of the article come to you and Dr. Finkler?
Yeah, so I think that those areas were defined now in retrospect. When we were getting ready to respond to the crisis we just focus on the outcome that we were trying to achieve, which was how can we provide safe and effective care to patients with COVID-19 that presented to our hospitals, and also continue to provide safe and effective care to all of the other patients that we needed to continue to take care of. And then as a result of being focused on that outcome, we really needed to expand our roles as clinical leaders, which I feel that prior to COVID-19 had been very focused on staying within the walls of the hospital and to think in a certain way. Again, to achieve that goal of meeting the demands of the pandemic, we just needed to explore new areas, things related to the first one that we talk about, trying to forecast what will happen short term. If you think about how traditionally in hospitals we do our strategic planning, it has been historically very different. We try to plan for the next 2 years, and things really don't, for the most part, move very fast. But with COVID-19, it was very different. And we recognized that we just needed to plan for the next 2 weeks in front of us. And sometimes we needed to adjust those plans later in the day. So that's where that first function of forecasting became critical. And then we had to see what tools we had around us to try to inform those decisions. And we talk in our article about the positivity rate in our urgent care centers. That's something that we've never used in the past and has become a very reliable way to know when more or less 2 weeks after we see that increase in the positivity rate in the outpatient setting, we start to see that in the inpatient setting. Data is another example. We really redefined the way that we use data to improve clinical performance. And the other one that I mentioned, that I will mention out of the 5, that is very important, is this concept of really getting outside of the walls of the hospital. I feel that we've always talked, especially from a population health perspective, about the importance of clinical leaders to really get outside of the hospital. And even though we talk a lot about that prior to COVID, I'm not sure that we were very effective in doing it. But with COVID-19, we had no option. And when I say getting outside of the walls of the hospital, I refer to engaging with the community, engaging with the media, engaging with external partners, engaging with the government and elected officials. That role of almost like an ambassador for the healthcare system, I feel represents an expansion in the skills of clinical leaders during COVID-19.
Yeah, it absolutely does. So in other words, COVID-19, the pandemic really has kind of been a game changer in terms of opening people's eyes to the possibilities of rethinking how we do clinical transformation?
Absolutely, because if we think about prior to COVID, we still have this expectation of transforming our healthcare system in the United States, mainly around the idea of how can we decrease waste, how can we improve outcomes, and how can we help our peers improve their clinical performance. And a very key idea around clinical transformation is the idea of standardizing clinical practice. So those were all ideas that we knew were very important for transformation. During COVID, we really didn't have an option. We experienced great pressure to have to deliver on those goals of standardizing, of using data to improve performance, of getting buy-in from our workforce. And for the first time in our system, we struggled prior to COVID to find ways to, let's say, treat pneumonia the same way or sepsis across all our different hospitals. So, the concept of a standardization in clinical practice is one that we tend to struggle with. COVID-19 was an example of acting as one system, identifying based on the evidence what were the best practices, finding a measurement system that could give the visibility to our doctors and everybody practicing in our system of how they were doing in reference to that standard, and then some accountability to make sure that we were delivering what we wanted. So I will say that COVID really accelerated how to be able to deliver on those transformation goals, because honestly, we didn't have an option at that point.
Right, exactly. Doctor, share with us, just walk us through for a couple minutes, your process in developing your new, the analytics architecture and processes that you have created during the pandemic.
I think that at a very high level, and then I'll get into specifics, has been a shift from focusing on outcomes that at the leadership level we need to achieve, and then engaging our front lines to understand what are the fundamental processes behind that outcome that really matter, and then trying to understand them, create visibility, and help our front lines influence how they control those processes. That's really what ultimately drives the outcome.
One of the things that's fascinating to me, Doctor, is the idea of both top down and bottom up and across ways of interacting around this. In other words, everyone figuring out what's important, sitting down at round tables or virtually round tables, agreeing on what's important to pursue and then pursuing it. In other words, the decision-making and the governance are moving in all directions, up, down, up, across. And that is one of the things that I think is particularly interesting that's been accelerated during the pandemic. Does that make sense the way I'm framing it?
Absolutely. The literature is very good in terms of how to do transformation. And I think you describe in an excellent way what is the way to do it. This cannot come from the top. You need to engage your front lines, and they are the ones that know how to transform and what are the things to go after. And so the fact that we had done a lot of work in clinical transformation already really set the basis with our doctors, with our workforce. And really what happened during COVID was that pressure that there was no option, but we needed now to take that playbook and we needed to turn it into a reality. I want to go back to where you asked me about our shift in how we use data, because I want to use an example.
Please.
If you think about driving a car, imagine that you are driving a car, but you don't have in front of you a speedometer. You don't know how fast you are going. And imagine that you get 2 months after a report that tells you how fast you typically go, and maybe a message that sometimes you are going too fast and that you need to, decrease the speed when you drive. That will be very difficult to relate to if 3 months after you get that data and you really don't know what that means. What is happening? When is happening? So what we did is say we cannot just rely in sharing outcomes where there is a lag. We need to bring that information the same way that when you are driving, you get in real time how fast you are going and you know how to influence that. We need to put in front of our clinicians real-time data in a way that they can react right away.
Yeah, absolutely. I love that analogy, Doctor, because no one would want to be driving down the highway not knowing for 2 months how fast they're driving, right? That would be really bad.
Well, and with COVID, what that means is that the outcome of interest was how often are patients staying in the hospital, with the goal of if we can safely discharge patients sooner, that will increase capacity and that will improve throughput. But we realized that telling a physician, hey, your patient is staying this long in the hospital, if you can reduce that, that is not enough. So as we described in our article, we realized that things like how long were patients on remdesivir, whether they were using remote monitoring and discharging patients that qualify for that early, whether they were being compliant with order sets. Those are very actionable pieces of data that then our doctors could relate to and then take action real time.
And the other thing I think about all of this that was so interesting was, or has been, because it's ongoing, is not only were you and your colleagues and others nationwide and even globally trying to figure things out in real time, the need to act on the data was also in real time, very immediate, rather than, well, this is something that we should maybe think about, 5 years from now. No, it was in many cases per capacity. And if you'd like to talk about that, that would be great. It was, well, how do we make sure we have the right staffing and PPE and supplies for the next 3 days, right? How did that play out in real time in your organization?
Well, I've mentioned several times our doctors, but it really, to get to that level, which you are right, that's in a system, in order to achieve the outcomes that I'm talking about, how to do that, you really need the whole team.
Yeah.
So we had to work with our pharmacists, our nurses, our care managers to really create that level of intensity around what were we trying to accomplish. So in the example of length of therapy for some of the COVID-19 treatments, we had our pharmacies literally doing reviews in all the patients, identifying opportunities, and then reaching out in real time to doctors and saying, hey, what do you think about maybe this idea or this idea, and providing feedback based on evidence. So I guess my answer to that is that you really need to engage the whole team to really then accomplish that.
Yeah, absolutely. What have been the biggest few lessons learned, Dr. Herrera?
That a big lesson from a clinical leadership perspective is that I think as clinicians, we have a legacy of not feeling comfortable with failure. And what I mean by that is that if you think about in clinical medicine, let's say that you are a surgeon, where we embrace a culture of high reliability and trying to minimize defects and failure, and it's the right thing to do when you're taking care of a patient. Imagine that you had in the clinical setting a failure rate when taking care of patients, or let's say 20%. That will be completely unacceptable. Now, when you switch to an innovator mentality, you have to embrace the idea that when you are trying to innovate, if you have a failure rate of 20%, that's actually relatively low for innovation, where you are trying to do rapid cycles of improvement, having maybe several things at the same time. Some of them may not work, and that's why I use the language of failure. But then the key is to learn fast from that failure and then adapt and then move on to something else. Yeah. To me, as a clinical leader, I feel that that's one of the biggest shifts in mentality, really becoming comfortable with the idea that not everything is going to work. And in our paper, we share and highlight all the things that work that resulted in great clinical outcomes. Behind many of those, there were things that we tried that didn't work, but they realized they help us learn to then the next iteration have something that was successful. So to me, that's one of the biggest lessons.
Wonderful. And what do the next couple of years look like for you and your colleagues in terms of leveraging analytics for clinical transformation in your organization?
When we look at healthcare right now, we still have the expectation to continue to transform. One thing that is different now is that we have constraints related to our workforce. As we know, and this is a national problem, several of the professions connected with healthcare, and mainly things like nursing, are experiencing constraints and staffing shortages. So I think that now, as we transform, and that just adds a new variable to the transformation equation, now we need to think about transformation and transformation initiatives that account for workforce shortages. And I think that, first of all, that's again a new thing that I don't think it was created by the pandemic, but I think we were in that trajectory already, and the pandemic accelerated what the state that we're in. I believe, and we have some examples here already, that the only way to fix that is by really leveraging a culture of innovation. We will probably not have a workforce again as we know it. So we are going to have to leverage things like automation, remote monitoring, and embrace a lot of mainly technologies that really bring pressure down in our workforce around tasks that can be perhaps automated. I think that the use of sensors, and again, the concepts of remote monitoring and getting data through wearable devices are going to create both an opportunity to automate a lot of collecting that, but it's also going to come with the challenge that now we're going to start to get into big data, machine learning, and AI to process all of that. But then that might take us to an environment where our workforce maybe doesn't need to then worry about collecting all that data themselves. But we have systems that filter a lot of that and then just bring attention to the settings where a human intervention is necessary.
Wonderful. Absolutely wonderful. Very last question, Doctor. Advice for our audience as they move forward themselves to leverage data for clinical transformation and other important purposes. I know almost everything you said here has had implicit advice embedded in it, but any explicit pieces of advice you'd like to share?
Yeah, I will say mainly two things. One, for organizations, the demands of COVID-19 have created access to a lot of tools and resources and a lot of focus. I think that clearly help clinical leaders to be successful. But at the same time, as we move away from the pandemic, there is the risk that there is not going to be the same level of support, resources, tools available to clinical leaders. Yeah. So I want to connect all the success that has happened in many centers with that level of support. So that support should continue. And I think organizations need to figure out how they maintain similar support. Yeah. Number two, probably the final one, is really to embrace that innovator mentality and change that culture. Obviously, we are defined by achieving success and the outcomes that we care about, but we need to get more comfortable with accepting that not everything that we work on is gonna give the results that we want if we are really doing innovation. And I think that's gonna take a very big shift in culture, but it's necessary for the innovation and the transformation that we want to see.
Absolutely. Well, I just want to congratulate you on your work so far with your organization in this area and wish you the best going forward. What you're doing, Doctor, is exactly what everyone needs to be doing in patient care organizations across the country. We need to become more proactive. We can't just wait for disasters to overcome us. And when we're given the opportunity because of a disaster like this pandemic, we have to seize that opportunity. So I appreciate that you and your colleagues have been seizing it. And we learned a lot from you just now. So thank you so very much, and best wishes to you going forward.
Thank you, Mark.
Great to have you. This concludes this session. We'll see you again in a few minutes. Thank you very much to everyone who listened in.